Thank you, sir, and good morning to the audience. I'll be presenting on behalf of my colleague regarding certain series of cases of actually not CSER but subretinal fluid spectrum of cases. So this is a standard classical CSER and various modalities of imaging. Just to recapitulate what we are dealing with. So, first of all, we talk of a case in which a 31-year-old young person, which 3 to 4 week of history of blurred vision, uh, was treated with TS substitutes as computer vision syndrome, MGD, and that kind of spectrum of disorders. However, later on, it's only during his fourth visit that his fundus was evaluated, and this was the picture. Now, this is the standard young person presenting with subtle diminution of vision and metamorphopsia, CSR. But why did we present this case? Because fundus was not seen in this case. It's only on third or fourth visit the patient is actually being seen. Even non-mydriatic fundus was not seen in this case. So later on, he was even his we took help from our psychiatric colleagues, and he was managed as a case of CSR. Moving on, so now there is a other spectrum of cases in which it may not be CSR, but it is being treated just as CSR because there is some subretinal fluid. So in this case, we have a 23-year-old lady presenting it again subtle definition of vision in unilaterally, and since the vision was okay, she was just being corrected with minor correction in spectacles. And only later again also in these cases was the fundus seen. And here we see this picture, and therefore toxoplasma was assay was done, and later on it was proven and it treated with clindamycin or Ozurdex. So again, akin to previous case, fundus evaluation is done only during later visits, just because she was young. Again, we have a 22-year-old lady presenting with color vision deformity during her screening evaluation for occupational entry to a professional course. In this case, screening for military recruitment, wherein she was found to have color vision defect. And when the fundus was seen, this was the picture. And based on the morphology, we can see the RPE defects, and this was diagnosed as a case of cone dystrophy. And later on, she was counseled because in future she needs to bear kids and what is the prognosis of children and all. And of course, she was counseled on preserving her sight using UV protection. Again, a 16-year-old girl who was a aspiring competitive swimmer who presented with uh, moderate diminution of vision in one eye and treated as anterior uveitis with unexplained vision loss, and then again found to have inflammatory cause, and later on it was found out that it was a CNVM and not just a subretinal fluid of some cause. So what was missed in all three cases was the fact that they were young ladies and not men. So it is seen that this simple fact is being forgotten by people who are forgetting the epidemiology of CSER, that it is only men who are generally predisposed to these cases, and also that even in subtle diminution of cases, in cases with subtle diminution of vision, the ophthalmologist should insist on carrying out color vision checks and contrast sensitivity and non-mydriatic fundus examination. Even in a busy OPD, if the patient is coming for the second time and the patient is worried regarding the symptoms, this should prompt us to consider these tests. Then we have a case of diabetic, who is a young diabetic presenting with subretinal fluid, and we have a OCT scan in this person in different machines. This is the picture which is shown in Cirrus 5000, and here we see the inner retinal thickness to be that is CMT to be 155 microns. Whereas if we move to spectralis, it gives a reading of 385. Now, if we just rely on technicians who write on without seeing the photograph, we will just rely on technicians who may just give us the CMT and go ahead with it, and tend to prognosticate this case. We may fall into a trap. So this is because of segmentation error in this case. Whereas wide field OCT gives us a more reliable picture in this case. So what is this we are dealing with? So further angiography and FAF picture gives us there is a hyperfluorescence leakage along the superiotemporal arcade, prompting us that there may be something else, and there is fluid tracking sign. So there is CSCR as well coexisting in this patient who is status post PRP. So this is not just because of the diabetic changes, this is a CSCR in a coexisting in a diabetic. What about this kind of picture in which we are treating the patient as a case of CSR and we find this hyper-reflectivity in the intraretinally? So this is to be taken cognizance of, and we can see there are two strata of fluids. One is SRF, one is below the RP. So this is prompting us to consider other diagnoses such as CNVM. So just because somebody is diagnosed as CSCR, should we not do OCT in every follow-up? That is when we call them for monthly or 3-monthly reviews. The answer is no. We should actually do the OCT every time a patient is visiting us, because some surprise may be lying. Because all said and done, CSCR does also have about 4 to 5% chance of developing CNVMs. Though the clinical clue of developing CNVM such as hemorrhage is very evident, but then by the time the patient is presenting with hemorrhage, it's quite late, and we would rather diagnose it early if the CNV is existing, and treat it at the right time. So the OCT clues are important, such as the ones we discussed, which includes intraretinal fluid, any segmentation, and any choroidal thickness associations. We know that in CSCR the choroidal thickness is more compared to other disorders. And also, if there is any occurrence of new hyperfluorescences, as this photo demonstrates, we should also consider CNVM, because we should not confuse this with multifocal CSR, because there may be CNVM happening simultaneously in these cases. So the take-home messages is, in this spectrum of people, of young people presented with subtle diminution of vision and metamorphopsia, we should consider doing color vision and other macular tests such as contrast sensitivity and photo stress test. Fundus evaluation, even if good visual acuity of 6/9 or 6/6 parts is present, we should insist on it, even if in a non-mydriatic setting. Gender should be in our mind, that females are generally not predisposed to CSR, and we should look for OCT clues and acquire scans during reviews. Laterality is also important. If somebody presenting with bilateral symptoms, we should consider systemic conditions or any dystrophies. And all in all, we should summarize it by thinking that SRF in all young individuals is not always CSR. I conclude.